Good morning, everybody. Wakey, wakey. It's time for Morning Glory. My name is MC Kalia, and I'll be your captain for the next 1 hour, 30 minutes. Let's have this conversation going.
Ruto of Tophill Hospital, a brain and spine specialty hospital dedicated to providing extraordinary care through competent doctors and other medical personnel from premium institutes with knowledge on the latest and exceptional medical technologies. With a capacity of over 70 operational ward beds, over 30 specialists and consulting doctors, Tophill Hospital is a modern level 5 facility equipped with 12 state-of-the-art ICU HDU beds and 2 modern HEPA-filtered theaters with laminar airflow. Our aim is to provide comprehensive quality services at an affordable cost to the community, which includes but not limited to neurosurgery, radiology and diagnostics, MRI, CT scan, X-ray, ultrasound, endoscopy, ECG, EEG, pediatric cardiology, physiotherapy, orthopedics and trauma, pharmacy, laboratory, theater, ICU and HDU, obstetrics and gynecology, general surgery, maternity, psychology, psychiatry, comprehensive wellness checkup, dialysis and urology, oncology, dental care, ENT surgery, nutrition and dietetics. For ease of movement and transfer of patients, the hospital has 2 modern critical care ambulances equipped with ICU facilities and available 24 hours. Tophill Hospital is located in a serene environment away from noise and has a cafeteria with fresh, nutritious foods, not forgetting ample parking for all clients. Tophill Hospital is NHIF accredited and accepts medical covers from a number of insurance companies. If you're looking for the best customer care and patient experience and to be attended within the minimum waiting time possible, reach us through the website www.tophillhospital.com or call 0782 121214, or you can also call 0782 900090. You can also email us through info@tophillhospital.com. Tophill Hospital, exceptional technology, extraordinary care.
Of course, it is the 10th day of the 5th month, that is May 2023. My name is MC Kalia, and this is the Morning Glory Show, the most comprehensive talk show in Kenya today. And we're coming live from Dawi Free Photography. Dawi Free Photography is situated in Eldoret at a place called Zion House. So anytime you need anything that goes into video and photo production, consider working with Dawi Free Photography. Dawi Free Photography gives you images beyond imagination. So if you're looking to, you'll be having a wedding anytime soon, and you'll be having any other work that you need it well documented, then this is the right place to come to. If you need to dress to be addressed, D-Square is the place to go. D-Square Fashion House is situated at the 4th floor of Ketia's building in Eldoret. And right now, they also have a school. So that means that if you need to take up fashion as a career, then you need to enroll at D-Square School of Fashion, Design and Tailoring. The goodness of studying from D-Square school is that you're also able to access the fashion house. And so anytime you need to do practicals, then it becomes easy because both D-Square School and D-Square Fashion House are situated at the fourth floor of KTS building. Now it is a healthy, wealthy, wise Wednesday, and with me today on set is Dr. Kevin Ruto. He's taking us through common cardiovascular diseases in children. Of course, we had introduced this topic at some point, then we had technical hitches during that day. So today is the day to tackle it completely, and so I hope pia daktari leo ameomba. So we'll be tackling common cardiovascular diseases in children. These are just heart diseases that may affect infants and kids. So daktari, I'll give you a chance to say hi to our viewers, then go ahead and introduce the topic to our viewers.
All right, thank you, MC Kalia, for the warm welcome. Yet another time, I think I've become one of your most frequent visitors here. So, to our viewers, I would say welcome to our Morning Glory show, the Healthy, Wealthy, Wise show. Today we'll be tackling a few things on common cardiovascular diseases in children. Basically, what we mean by that is, what are these common heart diseases that usually affect children? So that is basically what we'll be talking about, or in other words, what we further subdivide into those that are congenital. Congenital meaning those diseases that are actually children are usually born with. Then others, we are going to talk about some of the acquired diseases that we get in early childhood. Some of them being rheumatic fever in particular, that is rheumatic heart disease. So basically those are some of the things that we'll be talking about today, and welcome to the show.
Okay, thank you so much. And if you're watching at home, of course, make sure that you help us share the broadcast. Tell a friend who is not watching that Dr. Kevin Ruto of Tophill Hospital today is teaching something so important. Of course, I realized the other day that will help. Some of the people wait until when disaster strikes, that event they tend to seek for knowledge. But then I would encourage that you take such opportunities to share with family and make sure that you improve your know-how, especially on matters of health. So daktari, feel so welcome to the Morning Glory show. Of course, you said you've been one of the most frequent visitors on this show, and it is always a pleasure to have you on the show. Now let's go ahead and now tackle we say the bull by the
by the bull by the horns. So, Daktari, what actually causes? You've of course said there are those that are acquired and there are those that are congenital. So maybe let's start with congenital heart diseases. Take us through it. What exactly does that even mean?
Okay. One thing first I must say is that at Tophill Brain and Spine Hospital, we offer some of the best services, especially when it comes to pediatric cardiology, and our lead doctor, Dr. Myra, who also happens to be one of our leading hospital directors. Straight into the topic of today, we'll be talking about the congenital. Congenital, as I said initially, means these are heart conditions that children are usually born with. And as we mentioned earlier, we said that children, basically in the womb, their blood circulation usually bypasses the lungs for one reason. It's because at that point in time, a majority of the nutrients, a majority of the oxygen, they acquire from the mother through the placenta, that is from the placenta through the umbilical cord into their circulation. So they tend to usually bypass, okay? So there are some of the mechanisms, some of the heart, I would say some of the heart features that usually facilitate that. And as you mentioned earlier, is that the heart usually has 4 chambers. That is the right side having the right atrium and the right ventricle. Then going to the left, that is where you have your left atrium and the left ventricle. Okay? So those are the chambers of the heart. Then the heart usually also, in the human body, you have 2 sorts of circulation. You have something called pulmonary circulation. There is a circulation from the heart all the way to the lungs and down to the heart again. Then you have systemic circulation, that is now from the left ventricle all the way to the rest of the body. That is what you call systemic circulation. Basically, the purpose of pulmonary circulation, that is from the heart to the lungs, is for you to acquire the oxygen that you require. Then from there, blood has to go back all the way to the lungs so that it can circulate to the rest of the body. That is what we call systemic circulation. Now, in utero, what happens usually, there are a few features that tend to divert this circulation. So in the heart, we usually have something called, between the right atrium and the right ventricle, we usually have a septum called the atrial septum. There we usually have a hole that usually facilitates, once blood gets to the child's heart, it diverts to the what? It goes to the left, to the left atrium, to the left ventricle, then systemic circulation without really having to go to the lungs, because already it's oxygenated from the mother. That is one. Number two is in childhood, there is usually something called patent ductus arteriosus. A patent ductus arteriosus, or ductus arteriosus to be simple, is it's usually another diversion of blood in case it gets into the in case the blood gets from the right atrium into the right ventricle and it's pumped into the pulmonary into the pulmonary trunk. It does not go to the lungs, but rather it is diverted to the to the aorta, so that it just goes directly to systemic circulation. So those are some of the heart features that actually are there in utero before a child is born. But once a child is born, usually that tends to close, and those two diverts tend to close as soon as the baby cries, so that at least they can now take up their own survival. So quick into congenital heart diseases, therefore. I'm going to divide them into two. Actually, even before I go into dividing them, there are some of the risk factors that are associated with the anomalies that you get in childhood. Okay. Some of the major risk factors include family history. Family history of cardiac disease. There is someone, either a first relative in your maternal side, your paternal side, has been having a problem with their heart, maybe, that has been running in the family. There is one risk factor. Another risk factor is when there are infections, and there are infections in child, maternal infections at the time of pregnancy. That is another risk factor that tends to predispose you to some of those congenital heart diseases. Number three, of course, we have what you call genetics, abnormalities in genetics. These abnormalities in genetics include some things like trisomy 21, which is Down syndrome. I guess you've ever heard it before, the Turner syndrome. Usually those are genetic abnormalities that tend to interfere with the formation of the heart. Of course, besides that is nutrition. Proper nutrition during pregnancy cannot be, I can say it's irrepressible, and that is why we tend to focus on good supplementation during pregnancy, so that at least you can be able to handle a few of the things that may tend to arise during that period of pregnancy, during the child's formation and all that. And of course, number 4, 5, and the rest include some of the risks that we tend to expose our mothers to during the time of pregnancy. Drugs that we prescribe, drugs such as phenytoin that we use commonly for control of convulsions. At times, we tend to expose our mothers to unnecessary investigations. You get a pregnant mother, you haven't taken adequate history, and therefore they are pregnant, you tend exposing them to maybe radiation such as CT scans repeatedly. They tend to interfere with what? With formations of the formation of the baby in utero. So those are just to mention but a few of the risk factors that tend to predispose us to the same. Now, quick into our topic of today, congenital heart diseases. So what happens now?
And of course, Daktari, before you go there, somebody would ask a question. Is there a way that diagnosis can be done for the same while the baby is still in the womb, or it must be that it will be diagnosed most of the time once the baby is born?
So a majority of the time during the third trimester, that is during the time you're almost delivering, there are a few tests that we usually tend to carry out because one is an ultrasound. Just a basic ultrasound is it's a basic imaging technique that an obstetric ultrasound, you try to look at the baby in terms of gestation, in terms of the weight, in terms of dynamics of the heart. Okay, so there are those tests, one of them being what? An ultrasound. Whenever you do that and you notice something abnormal in terms of flow, there are those that you can actually intervene in utero, whereas there are those that you cannot intervene. Another test that we do is there is something called amniotic fluid sampling. Amniotic fluid sampling, you've done an ultrasound and you've noticed that this child does not seem to be forming well. The circulation of this baby in utero does not seem to be proper. So then what do? You take an amniotic fluid. An amniotic fluid is just a secretion that tries to neutralize an so they tend to secrete some of their genetic matter into that. So you can take it for analysis and you can notice, especially for those that have genetic anomalies, you can be able to actually pick them in utero before even the child is born. So yes, there are tests, quite a number of them, that you can do to diagnose these congenital heart diseases. The only big problem is intervening in utero. Okay, yes, you've diagnosed, but now we usually get so much challenges whenever we are to intervene to try and sort it out before the child is born. And the main reason for that is I would say these are defects. These are anomalies that usually you need to close them. You need to do at times surgeries on them. At times there are those that you give medications that might help, but a majority of them actually you have to undergo some surgical intervention so that you can be able to sort them out.
And once again, of course, before you now go to the topic, somebody would ask about the statistics. How often do you see these in children in this era?
Congenital heart diseases, as far as statistics are concerned, I would say it's actually on the rise. Do not have quite the figures with me, but usually the reason as to why we say probably we might be seeing a rise in the same is because a majority of children born with these congenital heart diseases, whenever you do not give early intervention, okay, or early diagnosis, their lifespan is usually very shortened. So in the past, before we got good diagnostic material, good technology, advanced technology for diagnosis, a majority of these cases were missed, and a lot of them actually that happened to be delivered usually lived a very short lifespan. They wouldn't go beyond the age of 5 and they would die because of the same. But now, due to the current improvement in technology, good detection and intervention, of course, now these cases we've been able to get them more, we've been able to intervene more, and a majority of them have actually gotten to live to adulthood. They live their full life without getting so much problem. So I would say reason why we are saying there is a rise is because of the increased the improvement in technology for diagnosis and for intervening once you've diagnosed. Yes.
Okay, thank you so much. Of course, I had interrupted you, so now let me allow you to go ahead.
Yes. So the next thing, therefore, that we are supposed to talk about after that brief introduction was to try and get to know what are some of these congenital heart diseases that we are talking about. One, we usually divide them into two: cyanotic versus what? Cyanotic. And as we mentioned earlier before, cyanosis is bluing discoloration of the skin, especially that usually happens when you have inadequate oxygen supply into the body organs, for one reason, especially to the periphery. So whenever you do not have adequate oxygen supply, you tend to get some bluing of the peripheries, especially of the nail beds and all that. Those are cyanotic heart diseases. Cyanotic. We said in medicine that is a negation. A negation is in the opposite side. So as cyanotic are those heart diseases, therefore, that do not what? That do not give you blowing of the extremities, or that do not compromise on oxygenation of the rest of the body. So cyanotic heart diseases, how they come about? In these congenital heart diseases, there is usually a shift or a diversion of blood from the right ventricle or from the right side of the heart. Blood in the right side of the heart, we usually say that that is deoxygenated blood. It does not have oxygen. This is blood that has moved, circulated all through the body, and is now going back to the heart so that it goes to the lungs to get oxygen so that it can be supplied. But now for cyanotic heart diseases, that blood in the right side of the heart is diverted to the left. So you are diverting blood that is not oxygenated to the left side of the heart. Then once it gets to the left side of the heart, now it starts circulating into the systemic circulation. Definitely, therefore, you'll be recirculating blood that is not what? That is not oxygenated, because you've bypassed the lungs. So that is what happened in cyanotic heart diseases. In cyanotic heart diseases, cyanotic heart diseases are basically heart diseases that cause a left to what? That cause a left to right shunting of the blood. So you are shunting blood that has come from the lungs, and you are shunting it to the what? To the right side, which is the deoxygenated blood. Then whatever remains goes into systemic circulation. So basically, there is no mix-up in terms of systemic circulation. You are not circulating blood that is not been what? That has not been oxygenated. Now, cyanotic heart diseases. Cyanotic heart diseases, where we usually have a mnemonic, the 5 T's. 5 T's of cyanotic heart diseases. One of them that we commonly see and not so much compatible with life is something called tetralogy. Tetralogy of Fallot. Tetralogy of Fallot. Tetralogy of Fallot was discovered by Fallot. So that is why it's called tetralogy of Fallot. And tetralogy means 4. We'll talk about it. So we'll talk about each of them individually. Then we have transposition. Transposition of the great vessels. To transposition is to, one, you change to the other side. Transposition, it's like you exchange. So that is what transposition means. Transposition of the great vessels. The great vessels that we have in the heart is usually the pulmonary and the what? And the aorta. That is number 2. So number 3, we have tricuspid atresia. Tricuspid is one of the valves that separates the right ventricle, the right atrium from the right ventricle. So whenever you have tricuspid atresia, you also get what? You also get cyanosis. Then of course we have total anomalous venous return. Total anomalous. It's totally abnormal venous return to the heart. Then others that we have there, we have truncus arteriosus is also another one. So you'll notice one thing about those cyanotic heart diseases. They have a T, tetralogy of Fallot, truncus arteriosus, transposition of the great vessels, tricuspid atresia, Epstein anomalies. Those are the cyanotic heart diseases. I don't know whether you would want us to tackle each and every one of them before we can go to the next.
I think, of course, we just give a general view of how they all look like, rather than going into each, because I know my viewer may not really understand much about. Yeah.
So basically, what I've told you about this is that there is, for these cyanotic heart diseases, there is a shunt, there is a mix-up of deoxygenated blood with what? With the oxygenated blood. Okay? And that is why you get cyanosis, bluing of the extremities. So how does it happen in tetralogy of Fallot, for example? Tetralogy of Fallot, there are like 4 sets of anomalies that you are having. One of the anomaly is from the right ventricle, you are supposed to be pumping blood to your lungs. But then you have something called pulmonary stenosis. So the part of the pulmonary vein that is supposed to be taking this blood to the lungs is what? Is stenosed. So then there is what? There is so much back pressure. So that is one of the anomalies that you get in tetralogy of Fallot. The second anomaly, therefore, is going to be what? Hypertrophy of the right ventricle, because hypertrophy in medicine means enlargement of the right ventricle. You are pushing blood through a narrowed opening, so that the right side of the heart will be trying to pump much harder, so that it does what? It pumps blood to the lungs. And what is going to happen, therefore, if you go to the gym, what happens to your muscles?
Become strong, like more masculine.
You become more masculine, so you get unakuwa huge,
So unakuwa na hati imeunga.
so inakuwa na the right side of the heart sasa inakuwa imeunga. That is what happens. That is the second anomaly that you see in tetralogy of Allo. And therefore, how does the heart compensate for that? Because it's struggling, so the one thing that it does, it gets stronger, then it creates an alternative route. It creates an alternative route whereby, instead now of going through this narrowed opening in the what? Narrowed opening in the pulmonary vein, it goes through a shunt between the ventricles, the right and the left ventricle. So through the septum, it creates a shunt, something called an atrioventricular what? No, a ventriculoseptal defect, a defect in the septum that separates the ventricles. Okay, so say that now it goes, instead of going up to the pulmonary vessels, it goes now to the left ventricle. So you're seeing what you're doing. You're now shifting blood from your right, going into your left through the ventricular septal defect. That is the third anomaly that you see in tetralogy of Allo. Then once there now, we get now something called what? An overriding aorta. So the heart, just at the opening where you've shunted blood to your right ventricle, to your left ventricle, the aorta just then comes and overrides just up there at the top of what? At the top of the ventricular septal defect, so that it will be receiving both blood that has been shunted from the right ventricle into the left ventricle, and some that has managed to get to the lungs and circulated all the way to the left ventricle, so that the blood mixes in the ventricle and it now goes into systemic circulation. So you see what is happening there. So that is basically what happens in tetralogy of Allo.
And Dr. somebody would now ask, in terms of treatment, how easy is it to resolve this kind of anomalies in kids?
So there are 4 deformities. So basically, the heart, after doing that, it undergoes structural changes. So instead of having the normal shape, it gets a boot shape, so that it can be able to accommodate all that in utero. Tetralogy of Allo, usually, if you miss initially, lifespan usually is very small. These patients do not need it, because you need to undergo an open heart surgery where you have to repair each and every individual of this, and at times you might need to leave a few of the defects, so that at least it can facilitate you. Like the overriding aorta, you cannot be able to do what? You cannot be able to correct. So the only thing that you are able to do is maybe you try and open up the pulmonary stenosis vessel, so that at least you can be able to pump more blood to the lungs and into systemic circulation. So a majority of what you do for such anomaly is surgical intervention. So you do surgical what? Intervention. Number 2 we are going to be talking about is truncus arteriosus. Okay, truncus arteriosus. Truncus arteriosus is also another, or let's start with those that are maybe simple to understand. Transposition of the great vessels. As I told you earlier, transposition of the great vessels means that instead of you getting from your aorta, which is the main vessel that takes blood out of your heart to the rest of your body, from the left ventricle, you get it from the what? From the right side. And the pulmonary vein that is supposed to be getting blood from the right side to the lungs, so that it goes to the back to the heart, is now on the left side. It is now getting blood from this region. So transposition of the great vessels, what is now going to be happening is you're having blood going into systemic circulation, and is deoxygenated because blood is moving from the right ventricle into the aorta into systemic circulation. It's deoxygenated. Then blood that actually is supposed to be getting from the lungs, from the lungs to the heart to systemic circulation, is instead going to the one that is supposed to be going to systemic circulation is going to the lungs. So it's the opposite. What do you do for that? Simple. You go in, then now you have to switch the two. Okay, those are very major heart operations. I don't think that a majority of them actually, we do them in a very few centers within the country. Okay, the third one, of course, is tricuspid atresia. Tricuspid atresia is the narrowing of the tricuspid valve. What do you do for that? Surgical intervention still. You go, you try and open up the tricuspid valve. And going into truncus arteriosus. A truncus is a trunk. Arteriosus is trunked arteries. So a trunk, then it branches. Usually from vessels, main vessels of the heart, we usually have the four. That is the pulmonary vein, the pulmonary artery coming back to the heart, the aorta, and the vena cava. Okay? In truncus arteriosus, actually, you have like three, because the pulmonary, the arteries from the pulmonary vein they come as a trunk, so that then now it branches. So instead of you having the aorta and the pulmonary vein, you have like a trunk, so then it branches into two. One to go to this side, then the other one to go to systemic circulation. That causes mix-up of blood. So basically, a majority of these cyanotic heart diseases, in summary for layman's understanding, so that I do not keep mixing you up, is there is a mix-up of deoxygenated blood going into systemic circulation.
Okay, and of course you've mentioned that most of them would need surgical intervention in terms of resolving. I asked about the statistics. You said it's quite common, maybe because of how we've been able to really find it out quite effectively. Then let's now talk about treatment. In terms of, first of all, I'll ask if are there insurances that cover such kind of diseases? Then two, what can be done in terms of prevention? What is there anything that we can do in terms of making sure that we do not have children that are born with these anomalies?
So, are there treatment? Yes, there are treatments. Before we go to treatment, maybe I can mention something quick on the acyanotic, so that at least we do not have to come back to that. So for the acyanotic heart diseases, basically, it's a shunt of blood from the left to the right. So it's oxygenated blood, basically, mixing. So you do not tend to get the bluing of the extremities, because you get a majority of your oxygenated blood. The only problem is that now you do not get the adequate of it. One of these is whenever you have a ventricular septal defect, an atrial septal defect, a defect that does not close between the atria. Okay, so blood moves from the left ventricle, from the lungs to the left atrium, then shifts to the right atrium, to the right ventricle, then to the lungs. So you are shifting oxygenated blood into the pulmonary circulation. That is one.
Which means it still goes back again to the heart, to the lungs, rather.
To the lungs.
Instead of going out into the body.
Back. So you see, it likes rotating. Then, of course, the little that remains, of course, not all blood will be shifted. Of course, there is some that will go to the left ventricle, then into systemic circulation. So it's a congenital heart defect, but now there is no shift from right to left. A ventricular septal defect is still the same thing. Blood from the left ventricle to the right ventricle into the pulmonary vessel. Okay? Then into the lungs. Another one is that thing called the patent ductus arteriosus. Once the baby is born, there is a reversal. Patent ductus arteriosus, basically what it's supposed to be shunting blood from the what? From the right, from the pulmonary vein to the aorta into systemic circulation in childhood, in utero. Once a child is born and cries takes their first breath and cries, the lungs open and blood now moves straight into the lungs. What happens after that? That defect is supposed to close. The shunt between the pulmonary vein and the aorta, it's supposed to close. But for some, it doesn't close. It remains patent. It remains open. Okay? So what happens therefore? Because the left ventricle is under pressure, okay? It's going to be a reversal of flow. Instead now of shunting blood from the pulmonary vein to the aorta, you have more pressure because of the heart pumping more on that region, and the blood now will be shunted from the aorta into the pulmonary vein than to the lungs. Okay.
And of course, just to be curious, is this what people usually say, wanasemanga akona shimo kwa roho, something like that?
Akona shimo kwa roho. So kuna mashimo mingi rohoni.
Anyway.
So if you notice one thing, all this that we've been talking about are just mashimo, because there are shunts that I said there are compensatory mechanisms in it for one reason. So an atrial septal defect is a hole in the atrium. A ventricular septal defect is a hole in the septum of the ventricles. So there is septum of the two atria, septum of the two ventricles. They are holes. Then of course the other one is also a hole between now vessels. Not the heart itself, but between vessels. So all those are holes.
Anyway, now
but a majority of those wenye unaambiwa ya kwamba wako na shimo kwenye moyo ni wale ambao wako na either atrial septal defect, ventricular septal defect, or atrioventricular. You can have both atrioventricular septal defects. So both. So those are just to mention but a few of those acyanotic heart diseases. In a majority of the cases, in terms of treatment, therefore, even before we go to treatment, let's talk about how do these children present. Because how do we get, in case a child is born and has a problem with their heart, what do you notice? How do you get to know that this child has a problem? Number one, I told you that children have very funny ways of presenting their problems. Some cry, some do what. But for those that have congenital heart diseases, you'll notice it's a child who tends to tire so easily. Mtoto anapewa kunyonya, ananyonya kidogo, then what do you notice? Anachoka, anaanza kupumua. Because as they try to breastfeed, they hold on their breath. So for those that are actually, those that get cyanosis, they actually go blue just from breastfeeding. A child breastfeeds and they turn blue because they are trying to do two things at the same time. Instead of breathing there, so they go blue. That is number one. Number two, these are children who get very tired. These very sleepy children. Number three, they tend to be born earlier. Nature has a way of eliminating that which is not wanted. Okay, that is where you see.
Of course, quote unquote.
No, it's the truth. Nature has a way of eliminating that which it thinks might not survive. Like, the world is a jungle. It's a survival for those that can exist. That is why dinosaurs are no longer there, because they could not. So that is what happens with the human body, and even with not only human body, with plants, with any animal. In case the body notices at some point, especially for those that have genetic anomalies, they tend to be born earlier. Okay? So they tend to be born earlier than it should be. A majority of actually those patients with those babies with genetic anomalies, a majority of them, the mothers lose those pregnancies during the first trimester. They hardly go beyond the third trimester because the body notices that this is something they need and it removes it. So they tend to be born early. Number three, they tend to be born with a very small weight. So Then, of course, number 4, these are children who do not develop as they should because of these anomalies. So you'll notice a 5-year-old, but very tiny. So they present with failure to thrive syndrome. So those are, then they get dyspneic. You notice that a child is breathing very fast. Why is this child breathing far much more than they should be? Then, of course, body swelling. The heart, the cardiovascular system is like an engine. It's like ile agari. It's the heart pumping, then it circulates. There usually needs to be that continuum for you to maintain a balance. But if there is a mechanical failure of the heart, so they tend to get something called edema. They get edematous. Mtoto amezaliwa, and you see their body is swollen. You need to suspect what? This child might be having what? A congenital heart disease. Then they get tachycardia. Tachy means fast heart beating. Cardia is heart. So you try to check their heart rate, and it is always on the higher side. What is the heart trying to do? To compensate. So that is how these children present. Okay? Now we can now peacefully go to the management. Treatment. Treatment options. For the cyanotic heart diseases, which usually those that have holes in the heart, as you call them, we usually want to do surgical intervention. We go in, we repair. So we repair the defects. There are so many methods of repairing them. Then luckily we also have very good technology and very good surgeons who've gone into good studies of how we can do repairing. And usually after repairing them, these children grow and they live actually a full life without any complications. That is one. Number 2, there are those that at times you'd want to give medications. One of them is what? Something like a patent ductus arteriosus that does not have any other what? Any other underlying anomaly. Some of the medical management that we give, we induce with something called prostaglandins. Prostaglandins are things that whenever you give, they stimulate closure of a PDA or a patent ductus arteriosus. One of the drugs that we usually use is indomethacin. So it triggers closure of those anomalies. So basically those are the management options. Management options, majorly surgical.
Majorly surgical. And somebody would ask the question now about, of course, sisi ni wa Kenya. Every other time we think of a disease, we want to think whether there is insurance for it. Of course, you've said it's quite common, and you've actually given you've gone ahead and even given us how to, of course you'll diagnose it at the hospital, because most of the children nowadays are born in clinic setups and all that. The next thing people would ask is insurance.
Insurance cover and congenital heart diseases. I would tell you one thing about health and medicine in general. When it comes to mothers, especially pregnant mothers, and neonates, especially children, we usually do not have a problem in terms of treating them, because they are some of the most vital part of human existence. So a majority of the insurances will cover for those surgeries, will cover for treatment of these children, will cover for a lifetime follow-up. So yes, fully covered, both for surgical interventions, for follow-up later on in the future. It does cover both NHIF and any other insurance. I'm yet to find an insurance company that will tell me that, you know, we cannot give you some amount for this procedure. And I've told them that we've done an echo, we've done an ECG, and it has showed that this child has this problem. Then they fail to cover. So a majority do cover. And just, of course, to take you back a bit, I am very sure you've heard me mention a few things: an echo and ECG. An echo, we said in terms of in utero diagnosis, we do those ultrasounds, we do those amniotic fluid testing. But once a child is born and we've diagnosed and we've seen that this child might be having features of what? congenital anomalies, we do something called an echocardiogram. An echocardiogram is you literally go and there's some machine that you use to visualize the heart. So we see, once we make that diagnosis, we just attach our reports, we send them to whichever insurance that it is, we give them a management plan, we tell them that we need to do this and this at this facility, and they do cover.
Okay, thank you so much for that. And of course, before we move into now the acquired ones, somebody would ask a question about prevention. Of course, you'd given us the risk factors. There are some of those that are preventable, or rather, if we were a little bit careful, we may tend to avoid these kind of complications.
Preventive measures, as you've already said, and as you've rightfully mentioned, are usually based on what are the risk factors that predispose us to the same. Okay? One of the risk factors was exposure of the mothers to drugs that cause malformations. During pregnancy, try to take a thorough history so that if this mother is suffering from a condition that you think, you might prescribe some medication that will interfere with the child's formation in utero, then you do not prescribe the same. That is one way. Number two, we talked about what? We talked about infections during what? Maternal pregnancy. Prompt treatment of the same can be able to do what? Of those infections that affect mothers during pregnancy can be able to help us what? Prevent congenital what? Heart diseases. Then of course nutrition. Proper nutrition that supports proper development. Okay? Proper supplementation of specific nutrients that you require. We say that mothers have to receive virtually all the nutrients that are necessary in the human body. Vitamins, proteins, carbohydrates, and everything, all the essential needs. And actually go to an extent of even supplementing some during pregnancy. We give them tablets, iron, folic, and all that, so that at least the child's formation is optimal. So providing adequate nutrition, maternal nutritional support is another thing that you can do to prevent. But of course, there are those things that you cannot not be able to change. We say that those things that nature has it. Things like what? Genetics. You might not be able to change genetics. You might not be able to change things like trisomy, a Down syndrome. You cannot change because these are conditions that arise from genetic malformation. So for those, unfortunately, we cannot change the cause. And what were the other risk factors you mentioned, if you can remember?
Of course, you mentioned family history.
Family history. That is also another thing. Those are some of those things that you usually hear me say, non-modifiable. You cannot modify them. I cannot change the fact that Kalia is from Kalia's family. And they have maybe a bald-headedness in their family. You'll get that back. So those are some of the things that you might not be able to change. Of course, that is why, for family history, that is why we encourage what? We encourage intermarriages. You do not have to marry from your village. Explore, go to South Africa, go to Japan, get a Chinese, you know.
Okay, you're making my producer smile, which is not a nice thing on this show. Anyway, that is Dr. Kevin Ruto from Tophill Hospital taking us through common cardiovascular diseases in children. Of course, is taking us through the congenital conditions, which are the ones that actually the children, or rather infants, are born with. And so in the next session, we'll be talking about those that are acquired. But then before then, let me look at some of the comments that we are getting here. Willie Comment says he's watching from Marakwet. Wilbert Aaron says good morning, tuned in. Kosgerab Chesi says good morning, tuned in. Thank you so much. Then Quincy says good morning, tuned in. Yesterday, somebody called me asking, ile hospitali ya Morning Glory kwa side gani? Good job. Thank you so much for that. Of course, your hospitali ya Morning Glory inaitwa Tophill Hospital. It is situated in Eldoret, Elgon View, just adjacent to the Boma Inn Hotel. So make sure that you visit Tophill Hospital in case you need extraordinary care, and they do it through exceptional technology. More comments here. Let me just sample a few more. Somebody says, Edwin is asking a question. Edwin Kim Sanai says, and how can I know if stress and anxiety is causing a problem to my heart? Of course, the first question I'd ask, if there is a link between anxiety and problems that are related to the heart, maybe that would be an extra question that Daktari would need to answer. Asbel Kemboy says, following the discussion, thank you so much. Mildred Sum says, good morning. Ambassador Alfred Sargent, all the way from Australia, says, a nice topic. Bonnie the Poet, okay, says, tuned in and ready to learn. Thank you so much for the nice comments that are coming in. And Daktari, maybe before we go to the acquired diseases, then we shall ask that we take a very short break, then come back to talk about the acquired diseases.
Karibu Tophill Hospital, a brain and spine specialty hospital dedicated to providing extraordinary care through competent doctors and other medical personnel from premium institutes with knowledge on the latest and exceptional medical technologies. With a capacity of over 70 operational ward beds, over 30 specialists and consulting doctors, Tophill Hospital is a modern level 5 facility equipped with 12 state-of-the-art ICU HDU beds and 2 modern HEPA-filtered theaters with laminar airflow. Our aim is to provide comprehensive quality services at an affordable cost to the community, which includes but not limited to neurosurgery, radiology and diagnostics, MRI, CT scan, X-ray, ultrasound, endoscopy, ECG, EEG, pediatric cardiology, physiotherapy, orthopedics and trauma, pharmacy, laboratory, theater, ICU and HDU, obstetrics and gynecology, general surgery, maternity, psychology, psychiatry, comprehensive wellness checkup, dialysis and urology, oncology, dental care, ENT surgery, nutrition and dietetics. For ease of movement and transfer of patients, the hospital has 2 modern critical care ambulances equipped with ICU facilities and available 24 hours. Tophill Hospital is located in a serene environment away from noise and has a cafeteria with fresh, nutritious foods, not forgetting ample parking for all clients. Tophill Hospital is NHIF accredited and accepts medical covers from a number of insurance companies. If you're looking for the best customer care and patient experience and to be attended within the minimum waiting time possible, reach us through the website www.tophillhospital.com.
Okay, welcome back to the Morning Glory Show at the Healthy, Wealthy, Wise edition. This day, the 10th day of May 2023. My name is MC Kalia, and with me in studio is Dr. Kevin Ruto from Tophill Hospital. He's taking us through common cardiovascular diseases in children, or rather what he prefers to call common pediatric conditions in pediatric. Okay, now take us through that. He said the other time he said common pediatric cardiovascular diseases. Now you see, I'm a small doctor. Anyway, so make sure that, of course, if you have any questions to ask, shoot them to Daktari this particular morning. Of course, thank you also for the nice comments that you've been sending, and thank you so much for tuning in and making sure that you acquire some more know-how about your health. Now, Daktari, now moving towards acquired. Of course, we've talked about congenital, which he said are those that the kid, or rather the infant, is born with. Now we're moving into those conditions that the children acquire them after birth. Daktari, karibu once again.
Acquired heart diseases. Acquired, you are not born with, but now during childhood, during the pediatric age group, which today extends, pediatrics actually today, as per the current, I think, constitution, children are up to the age of 18. So that is a child. So during this period, you can be able to get a heart disease for one reason or the other. Of main focus that we are going to talk, today we are going to talk about is that we commonly see is something called rheumatic fever, and of course it's secular, that is a rheumatic heart disease, which is a complication of rheumatic fever. Then of course we'll talk about further sequelae or further complications of rheumatic heart disease, which is infective enteritis. So those are the three things that we're going to talk about. Rheumatic fever, basically, this is a condition that tends to affect children between the ages of 5 to around 14 there, or about. And usually how it results is from, it's more of an autoimmune. Your body trying to fight itself in various organs in response to what you call beta hemolytic streptococcal infections. Beta hemolytic streptococcal infections, these are bacteria that tends to cause upper respiratory tract infections in children. So children usually between that age group of around 5 to 14, they tend to get these recurrent upper respiratory tract infections, tonsillitis, common cold and all that. Whenever they get a superimposed bacterial infection by these bacteria called beta hemolytic streptococcus, what happens? The body generates antibodies. Antibodies, these are warriors that fight these infections. These antibodies, when the body secretes them, it secretes them with a purpose of fighting particular components of the bacteria itself, various proteins that a bacteria has, so that it can break this bacteria down and kill it. Unfortunately, what happens in rheumatic fever, there is something called mimicry. Some of the beta hemolytic streptococcus has proteins that tend to mimic the structure of our own body proteins. Proteins that we get in our heart, proteins that we have in our joints, okay, and some that we have in our subcutaneous tissue. So are you noticing something? You get the bacteria, the body secretes antibodies to try fight the bacteria, proteins in the bacteria, then you happen to be having the same proteins as part of your heart, as part of your joints, and as part of subcutaneous tissue. So what is going to happen there?
The antibodies are going to start dealing with the body.
With the body. So that is what happens in rheumatic fever. Rheumatic fever. Your own antibody starts dealing with various parts of your body. Diagnosis. How do you get to know that someone has a rheumatic fever? There are 5 symptoms that are noticeable in patients with rheumatic fever. One is they get carditis. Carditis in itis, as we mentioned. You remember what we mentioned about in itis?
Maybe you need to refresh my memory.
It's an inflammation. An inflammation, itis. So you get carditis, and cardiac is heart. So you get inflammation of what? You get inflammation of the heart muscles and everything all the way to the endometrium. So you get a carditis. It affects your heart. That is one major criteria, what we call the Benz-Jones criteria for diagnosis of rheumatic fever. Number 1. Number 2, you get something called migratory what? Arthralgia. Naambiwa leo mtoto anakuambia niliumwa na hizi joints za miguu, kesho anakuambia hip. Naambiwa major joints, especially the knee, the hip and all. So they get that migratory arthritis. So they complain of joint pains. That is another major criteria. Then they get something called syndrome scoria. Syndrome scoria, or what we call the devil's dance. I think the virtuous dance. So child is seated, then you just notice they keep throwing their maybe arm, their leg, a very restless leg syndrome. That is something called syndrome scoria. Syndrome what? Scoria. That is also a major criteria for diagnosis of rheumatic fever. Then they also get something called erythema marginatum. Erythema is a skin lesion. Erythema is brownish discoloration of the skin. Marginatum is, you have something like a ringworm, okay, but now it's brownish. So at the margins, it's brownish. It's kind of pinkish to so there is erythema, is the coloration. Marginatum is around the margins, okay. Then of course they get what we call subcutaneous nodules. Subcutaneous nodules, they get some two small growths, so like two swellings beneath their skin. Those are some of the major criteria that you will notice in a child with rheumatic fever because of the response of the antibodies to major organs. So affects the heart, affects the joints, affects skin, affects subcutaneous tissue as the major what criteria. We go to the minor criteria. What are some of the other things that you notice in these children? They get something called what? Polyarthralgia. The other one was arthritis, migratory. Polyarthralgia is joint pains literally everywhere, and non-specific joint pain. So your child has been good until the age of 5, then they start now complaining of, oh, my joints are aching. Polyarthralgia. Then we have something called an ESR. An ESR is a lab test that you do. What you call erythropoietic sedimentary rate. It tends to rise. Then you get something called prolongation in QT interval. So a majority of other things that you get there. Then of course, family history and a previous history of rheumatic fever. Those are minor criteria, among others, that children present with once they are attacked by that thing. Okay? So in terms of diagnosis of rheumatic fever, you would want, a patient presents with such things, you'd want to investigate them. And as part of the investigation, one, you want to do two important tests first. Do an ASOT. An ASOT test is, ASOT is a product of the beta hemolytic streptococcus. Whenever you do and you find it positive, then you do this ESR, erythrocyte sedimentation rate, and you notice that it is also on a higher side. It tells you there is an ongoing acute inflammation from the same, and you are probably dealing with what we call rheumatic fever. Whenever you diagnose a patient with that, you'd want to go and dig further. Do an echo and see how is the heart function. Do further test, yeah, to see the heart functions. And after you've then diagnosed, usually for diagnosis, we do not even measure on what? We do not actually measure on these lab tests. We measure on the patient presentation, the major criteria. You attach it with some of the minor criteria, okay? Then a few lab tests to support your diagnosis. You make a definitive diagnosis and you start these children on prompt and adequate antibiotic coverage, okay? A majority of the time we usually give what's something called benzathine penicillin, Panadac. You treat them promptly, then you also have to be injecting them with what? This Panadac injection every month for at least 6 months. That is in acute rheumatic fever. Why are you doing this? You are preventing sequelae. You are preventing complications that arise from
Rheumatic fever.
From rheumatic fever. So that is just a nutshell of rheumatic fever.
Okay, and Dexari, of course, now that you've said there is a complication, then that means that once we do not handle the rheumatic fever quite well, then we now end up having you say it's called rheumatic heart
disease as a sequelae of rheumatic fever. So you do not treat rheumatic fever adequately, there undergoes changes in the heart, especially of the valves, the heart valves. Okay. Some of the major heart valves that are usually affected in rheumatic heart disease are the mitral valves. Mitral are the valves between the left atrium and the left ventricle, and the aortic valves. They are affected from what? From this rheumatic heart, from other sequelae. So they start failing because there has been prolonged inflammation. So they now thicken, they shorten, then the flaps are no longer good and compliant. So you get rheumatic heart disease. Whenever you do auscultation is you take your stethoscope and you listen to the heart. What you are going to notice, you are going to be getting murmurs at those regions. A murmur, the heart is supposed to be having two very nice sounds, like two. But you'll notice that between one heartbeat and the next, there is something like a so that is a murmur. Okay, that is what you get whenever you auscultate. Then from that you will know, therefore, that now you have a problem with your valves. And on further investigation, whenever you do echo, you will see those changes that have occurred on the heart. Rheumatic heart disease, a sequelae of rheumatic fever. How do these patients present? They now get into frequent heart decompensation because of abnormal circulation. So they get heart failure. How do patients with heart failure present? Number one is fatigability. Anachoka haraka. Mtoto alizaliwa vizuri, amekuwa nini vizuri, but the slight activity na amechoka. There is grading for that. Then they get dyspneic. Wanapumua haraka. They get episodes of difficulties in breathing. And of course, number three, palpitations. The heart pumping, very quick. Then of course they get generalized body swelling. So these are child. Now they grow, they are well today, then the following day unaambiwa ya kwamba leo amefura kila mahali, anakaa kuchoka and everything. You come doing investigations, echo, you get those heart murmurs. You do auscultation, you get those heart murmurs. You do an echo and ECG, you realize that, oh, actually the heart valves are not okay. So that is now what? Rheumatic heart disease. What are you supposed now to be dealing with? You now start putting them on what? Anti-failure medications. Because they have heart failure, you want to give them anti-failure medication. Anti-failure medications, therefore, you want now to focus on managing the symptoms that come with the heart failure. There is excess fluid overload due to inadequate pumping of the heart. You want to get that out. So you give them diuretics. Diuretics is things that make you urinate more, so that at least you decrease fluid overload in your body. That is number one. Number two, you want to give them something that tries to help their heart what? Pump faster. We give them something called digoxin or aminoglycosides. They help. They help in terms of cardiac function, contractility, and compliance, so that it beats better. Then, of course, for the tachycardia, the heart pumping force, you want to regulate that. You want to regulate that by giving them something that a bit slows the heart to the regular beating. Then, of course, there are those patients, because of the heart failing, the heart and the lungs are, it's like, they're like, what do you call, fraternal twins. They are not identical, but when one has a problem, the other one tends to get almost an equal measure of, an equal share of the problem. Because now, I'm supposed to be taking blood from you, then giving back to you so that you can circulate it. But you have failed. You are giving me, I'm trying to giving back to you, you umeshindwa kupump. So you overload me instead. So you get this what? Pulmonary hypertension. So you also want to give something to sort out what? Your lungs at the same time.
And Daktari, somebody will ask a question, is there a permanent treatment for this, or you'd now remain on medication for
a majority of the patients whom we diagnose with rheumatic heart disease, permanent solution medications. A majority of them, we put them on medications because of the complexity of the whole thing that comes already. Of course, there are those that undergo surgery. They maybe the valves are so markedly damaged, and you'd want to intervene, give them artificial valves. Those at times are a bit permanent, surgical intervention. But a majority of them, actually, you put them on what? Anti-failure medications. Some of which I've just mentioned to you. The body, whenever it does not get adequate of something, it adapts to the same. So some of these patients, you and me, if we were to measure your oxygen circulation as of now, it is probably something beyond 95, 90. But for these patients with both congenital and both for these acquired, you'll notice once they have this problem, the body adjusts to very low levels of oxygen saturations. That is why we usually even allow something beyond 75, 80 for as long as they do not present with these symptoms of tachycardia, tachypnea, or fluid overloading. We accept. We tolerate the same, because at times, no matter how hard you try to push, you never really take it to optimum function. But we boost when necessary. Of course, when they have so marked decompensation, we boost with what? With oxygen supplementation. Some of them have concentrators and even at home and all that. So that is rheumatic heart disease. Rheumatic heart disease gets also its other complications.
So there is an extra complication.
Yes.
So it is rheumatic fever, rheumatic heart disease, then there is...
you get to complications. One of the complications actually that we've mentioned is heart failure. So when the heart fails and when it gets improper contraction and all that, they tend to get something called arrhythmias. Arrhythmias is the heart not pumping properly. That is an arrhythmia. And when the heart does not pump properly, you tend to get several other complications. One thing that you'll notice is that I've actually mentioned a few. Pulmonary hypertension is a complication. But of importance is infective endocarditis. Your valves are damaged, not working as they should. Infective endocarditis comes in when your heart are damaged. So they get vegetations. Wanapata vegetations kwa those valves. Vegetation is, you get a bacterial infection, it goes and settles on your already compromised heart valves. Sawa? Then bacteria and these organisms actually usually tend to have a very funny way of doing things. They go and cushion themselves because they know if they are left open, the body's immunity fights them. So it cushions themselves. So they form microthrombi, on those what? On those heart valves. That is what we call now what? Infective endocarditis. Infective endocarditis, of course, we further subdivide them into various classes. An acute infective endocarditis or subacute infective endocarditis. For acute infective endocarditis, those are those that result from very virulent what? Very virulent bacteria. Actually, at times even affecting just a normal heart. So it doesn't have, actually infective endocarditis does not necessarily have to be as from rheumatic heart disease. For acute symptoms, those are bacteria that are so virulent that they just affect the heart valves even in their good state. But then there are those for subacute. Those are less virulent organisms, but they get a heart that is already compromised by rheumatic heart disease, or a heart that has already undergone what? A surgical intervention. You have a prosthetic valve, and now these things go and settle on those valves. So you get those vegetations. Whenever you get a vegetation in your heart or a thrombus, you know, the heart is like a vessel. There is blood flow. So have you ever gone to the river? Then you see water flowing, but then you see those vegetations that grow up by the side of the river, or maybe at the bedrock. So you see them. There was some vegetation that The water was just carrying. Then there is this one day you'll go there, then you notice what? The rain or maybe got near and it plugged it off. It's the same thing. So you grow vegetations, then with that you are compromising the heart valves further. So you tend to go into even further heart failure. That is number one. Number two, there will be this day that vegetation will do what? Will dislodge. And once you dislodge a vegetation, whether in the right side of the heart or in the left side of the heart, it has to land somewhere. If it's in the right side of the heart, where will it land? If it's in the right side of the heart, it will land?
The lungs?
Exactly. It lands in the lungs. Okay? So you are laughing with someone, they throw a very big, huge embolus to the lungs, and that is how they succumb. Because an embolus that blocks your lungs, pulmonary embolism, is actually an emergency. Because you'll no longer now be getting your blood to the lungs. It's already blocked by a what? By an embolus. Now, if it is at the left side of your lung, it dislodges. It will land somewhere at some particular part of your body. It either lands in the brain, it either lands at some vessel. Okay? It can even land in the heart itself, because the heart supplies itself with blood from the into the aorta, then it gives branches to supply itself. Okay? So it can land there. And if it lands there, sudden what? Cardiac death. Those are, so sudden cardiac death is also a complication of what? Infective endocarditis. Sasa.
Okay.
So those are just to mention, but up here. How do we manage them? Adequate treatment. Adequate treatment. Get to know that this heart is not so well. This child has had a rheumatic heart disease. This child has had a previous heart surgery. There are chances of getting this on the higher side. So follow up. A majority of them actually we give them Panadac treatment up to the age of 18.
Okay, Daktari, of course, because of time, we only have 2 minutes. I'll still add it to 5 with the permission of my director, Kim. Of course, first of all, I need to tell you that Daktari comes from Tophill Hospital. He is Dr. Kevin Ruto from Tophill Hospital. Tophill Hospital is a level 5 brain and spine specialty based in Eldoret, Elgonview, just next to Boma Inn Hotel. Anytime you need to get some extraordinary care, then you need to visit Tophill Hospital. And Daktari, as we wrap up, of course, you've talked about these kids being maybe more delicate than others. How can communities and parents and everyone who is around children who've had heart complications, whether congenital or acquired, how are we supposed to behave towards them? What should they do? What should they not do?
That is one very important question I think you've asked. It's a very, very important question. These children, due to how they present, at times you might think that they actually